technology, and it's happening right now, where people are having sounds in the background, and if you know, do not mute yourself and you're creating a great disturbance, which is actually then affecting the presentation, then I, as host, will then put you into the waiting room. In other words, you'll be removed from the meeting because, you're impeding the meeting. So when I mute you, just remain muted and then only unmute when you're speaking, because every little thing that you do with your phone, with paper, with conversation, your dogs, and your TV and radio, everything gets amplified and makes it impossible actually to have a fruitful meeting. So I know we're all learning, but then, if you do not comply, then I'm going to have to put you into the waiting room. So welcome everybody. And once again, thanks to Dr. Read. It started off with a telephonic conversation while I was driving, asking Dr. Read if she would speak, and then she promptly agreed, and then engaged with Megan from Allergan, who facilitated the entire process. And thanks to Dr. Read for that lead. And then Janice, the brand manager from Allergan, came in, and then together with the team and Galta from the office and the ECIPA team, we put this together and invited all our colleagues from around the country. With COVID, this is the great opportunity of COVID, and the positive spin-off is that we're engaging with our colleagues, throughout the country, whereas we would normally have just had PE colleagues here present. So with that, and I'm going to once again thank Allergan for readily sponsoring this meeting and towards improving clinical competence of our colleagues around the country. And I think repetition is a great thing. So I'm going to hand over to Janice Prinsloo from Allergan, the brand manager. You can unmute yourself, Janice, and address, and then you can share, or you may share your presentation if you have one.
Yes. Thank you very much. So good evening, everyone. I am Janice. I'm the brand manager for both the Optiv and Ozurdex portfolios. And Optiv is our range of products to treat dry eye disease. Ozurdex, on the other hand, is an intravitreal dexamethasone implant to manage macular edema of the retina. We have a glaucoma portfolio as well, where the ophthalmologist can prescribe various drops to manage intraocular pressure. And included in this portfolio, we have an implant called Zen that is surgically inserted in the eye as an alternative to eye drops to manage the high IOP. So I want to thank Dr. Govender and the team for allowing Allergan to be part of your meeting tonight, giving us the opportunity, with the assistance of Dr. Read, to talk about common eye conditions. At Allergan, we are committed to continued education to all stakeholders and really jumped at the opportunity to speak to you tonight. It's vitally important to understand when to refer some of your patients, as it could mean the difference for a patient between being able to see and not being able to see anymore, and ultimately affecting the quality of life. So as I mentioned, Optiv is our solution for dry eye disease, and I'm going to share a bit more with you right now. So I'm just going to share my screen. So if we look at dry eye disease globally, we're looking at about a 5 to 50% prevalence of dry eye disease. And if you think about the menopausal woman, you're looking at about 34% of that segment that struggles with dry eye, and up to 54% of your diabetic patients could actually have dry eye disease as well. And if we think about what is dry eye disease, we're looking at the fact that it's multifactorial, and it's really looking at the loss of homeostasis that happens if we look at the tear film. And this can ultimately lead to inflammation. So you start with tear film instability, it leads to hyperosmolarity, cell death, and ultimately inflammation. And it just continues being this vicious cycle of dry eye disease. And that's ultimately what we want to treat, because we want to stop this vicious cycle from continuing. So you've got your healthy tear film, you've got your unstable and your damaged tear film. If you look at your lipid layer right on top, and then your aqueous layer, and you get to those dehydrated epithelial cells. And this is where we want to actually fix the problem. So now your patient says they've got dry eye disease. They stand in front of that shelf in pharmacy, they can really pick up any artificial tear, and it will give them symptom relief. And that's what we want. But ultimately, we want to fix the problem, and we don't just want to treat the symptoms. And that is what makes our Optiv range so different. So yes, we've got the carboxymethyl cellulose, which is the lubricant. It's going to give you symptom relief. But what makes us different is that we've got osmoprotectants, and that is what is going to get us back into homeostasis again. And the osmoprotectants is what penetrates the dehydrated epithelial cell and ultimately stops that vicious cycle of dry eye disease for your patients. So why is this important? And like I said earlier, it really does affect the vision-related quality of life for patients. So dry eye sufferers may have up to 4 times more trouble with everyday activities. And this can be watching TV, this can be reading. If any of you in front of your computer right now, you've got dry eye, stinging eye, burning eye, you've got dry eye disease. So if we look at the symptoms, I think I'm in the way here. So if we look at the symptoms, we've got a dry eye, a stinging eye, a burning, fiery eye. Sometimes it can be teary, and in some instances, it can actually cause ocular pain as well. So, you know, who is this patient who's sitting in front of you? It can be the patient going through menopause. It can be the diabetic patient. They really struggle with corneal nerve sensitivity and desensitization that happens. Your allergic conjunctivitis, every time you script an antihistamine, don't forget that up to 50% of your patients could also have dry eye as well. Patients have had cataract surgery or LASIK surgery, and then all those medications. If you think about in the last week, how many times have you scripted a beta blocker, antihistamine, antidepressant, acne treatment, contraceptives? All of those medications may contribute to a dry eye as well. And there's such a large percentage of patients who don't even realize that they have dry eye. Starts out slowly, they get used to that feeling, and then it starts getting worse, and they don't even realize that it's dry eye disease. And then your contact lens wearers also generally struggle as well. So what is the solution for these patients? And that's where our Optiv range comes in. So we have the solution for not only day, but we look at for night as well. So Optiv Fusion, I think that's the one that we all know, that everyone knows. This is your artificial tear for your contact lens patients. It's contact lens friendly. Patient who has had surgery can benefit from the Optiv Fusion as well. And then we've got our Optiv Plus that has got the lipid included as well. So if your lipid layer needs to be treated, we add some oil there with the Optiv Plus. And then our new product is Optiv Omega. This is what we launched in March. And it's got all the components of Optiv Plus with the added benefit of Omega-3, which is linseed oil. And then I spoke about the osmoprotectants earlier. It's got a 4th osmoprotectant. So here we're just looking at newer technology. And then looking after that tear film at night, we've got the Optiv gel as well. So just a bit more of Optiv Omega. It's the only preservative-free eye drop in South Africa that has got omega-3, which comes from linseed oil. It provides rapid and long-lasting relief of symptoms. Convenient, it only comes in the single-dose units. It protects against your tear evaporation. The osmoprotectants help to enable hydration of the cells, and then no shaking required. So talking about the technology and moving forward and always coming out with something new. So we've got nano emulsion technology that's new in our Optiv Omega. And what that actually means is that because it's the tiny molecules in there, you actually don't get any blur with your Optiv Omega. And that is something that we've come to expect from an artificial tear containing lipid. We generally expect the blur, so you don't get that with your Optiv Omega. The polysorbate 80, that's also technology in there, means that you don't have to shake the product. There's no separation that happens, and your lipid is dispersed throughout your product. Then we've got the carboxymethylcellulose, which is your lubricant, giving you that rapid and long-lasting relief. And then across the board with all our formulas, we've got the osmoprotectant. So that is fixing your problem, basically, not just treating the symptom. That's the glycerine, L-carnitine, and erythritol. And then again, looking at new technology, we've got the fourth osmoprotectant, which is trehalose. And, you know, if I just want to sum it up in one sentence, it's really clear that the Optiv family gives you a simple day and night routine for instant relief from your dry eye symptoms. So thank you so much.
Thanks very much, Janice, for that informative presentation. May I ask if you could enlighten us of the potential side effects, if any, of these products? And secondly, in just day-to-day use, where you don't actually specifically suffer from chronic dry eye, but at times maybe, you know, spending too much time on the screen, would it be appropriate to use an Optiv product, and which one would it be?
Absolutely. So if we address the first question in terms of side effects, so your the whole Optiv range is really safe to use. We don't have any known side effects, and there's no age limit in terms of who can use Optiv, and then how long, so how many times a day you can use it as well. So it really is quite safe to use. Then in terms of for who is this, so absolutely, with the digital technology that we've got, the best thing to do is actually use your Optiv before you log onto your laptop or your iPad, and that will then help you in terms of that strain that you sometimes feel or that burning sensation, and it actually prevent that. So your go-to can be Optiv Fusion. It's contact lens friendly, and if you do struggle with, for example, a teary eye, sometimes that could be that you have a lipid deficiency dry eye, but that needs to be diagnosed either by your optometrist or your ophthalmologist. So preferably your eye care professional. But if in doubt, we always say go with your Optiv Fusion.
Thank you, Janice. I think many of our colleagues would be interested. Are there any questions to Janice? You may unmute and ask your question or stick your hand up. Don't see any hands. Your electronic hand, or unmute and speak. If not, your presentation was crystal clear, Janice, and I'm going to hand over to Dr. Sean Falkwain to introduce Dr. Olivia Read. Sean, will you unmute and do the introduction? Thank you.
Okay, am I unmuted?
Yes.
Okay. Good evening, colleagues. Please allow me to introduce Dr. Olivia Read. Dr. Olivia Read is an ophthalmologist in private practice at Life St. George's Hospital in Port Elizabeth, also known as Gqeberha. She completed a schooling in Johannesburg, where she excelled at sport and obtained provincial colors in swimming and hockey. She then went on to Wits University, my alma mater, and completed a MBBCH degree in 2000. An internship year was done in Cape Town at the Red Cross Hospital and Groote Schuur Hospital. And community service, she came to KZN, where she did community service at Ishawe Hospital. 2003 saw her doing obligatory UK travel and work experience, where she worked in accident and emergency medicine. And then in 2004, she decided to come back to Southern South Africa, where she worked in various senior medical officer positions in Cape Town and also in East London. She became an ophthalmology registrar in Cape Town at Tygerberg Hospital. And sometime in between, she completed her diploma in ophthalmology and eventually completed a fellowship in ophthalmology with the College of Medicine of South Africa, and also a MEd in 2010. In 2011, she took up an ophthalmology consultant position at Port Elizabeth Provincial Hospital, where she worked until the end of 2010. She has a number of publications to her name and has also attended numerous congresses and done many presentations locally and nationally. Her clinical interests include oculoplastics, cataract and refractive surgery, strabismus, and glaucoma. Her personal interests are mostly outdoor living, where she enjoys trail running, road cycling and mountain biking, hiking, photography and reading, and spending time with medical doctor husband and 2 boys. With such an impressive CV, I don't think that anyone has a doubt that Dr. Olivia Read is more than adequately and qualified to present to us a talk on common medical problems, common eye problems in general practice. So it gives me great pleasure to introduce Dr. Olivia Read.
Dr. Read, thank you, Sean, for that introduction. Before Dr. Read takes the air, just to let you know, in the third quarter of the presentation, Dr. Falkman will post the link to the electronic register for you to register to get your CPD points. Okay, over to you, Dr. Read.
Great. Thank you, Sean, for your very kind introduction. I'm just going to share my screen. Let me see. Sorry, I think I'm a bit digitally.
There we go.
There we go.
Yep.
Can everyone see it?
Yes.
Okay, great. Okie dokes. Well, as Sean introduced me, my name's Olivia Read, and I'm an ophthalmologist in private practice at St. George's in Port Elizabeth. And I've been asked to present to you guys on common eye conditions, their diagnosis, treatment, and when to refer. This is obviously a massive topic, and I'm obviously not going to be able to cover everything in detail. But I think the main thing that I want to get across is that there are many conditions that you guys as GPs can treat. And we want to identify those, go through the history and signs and symptoms of those, and how to treat. And then which conditions are important that for you to identify, to refer on to us as specialist ophthalmologists. So in order to do this, I'm going to give you some tips on eye examination techniques that may help you. We're also going to go through some common pitfalls, and I'm going to discuss a number of common eye conditions, go through the history, signs and symptoms, and when to refer. And I'm going to attempt to do all of this in 45 minutes. So first of all, I think as GPs, the only things that you guys really have in your armamentarium are your 2 eyes and and an ophthalmoscope. So obviously it's very important that you first of all use the ophthalmoscope, but that you also have an idea of how to use it. And I think the most important thing is also to always be systematic. So have some kind of system that you use when you examine the eye, start from the front and work backwards, and try and not leave anything out. I'm not sure if you guys are aware, but on the direct ophthalmoscope, you know, there are those hyperopic and myopic settings. If you actually put the direct ophthalmoscope on the +20 setting, and then look at whatever you need to look at, about 5 centimeters from the ophthalmoscope, you actually get a very nice magnified image of that. So it's great to look at the meibomian gland openings, orifices, the puncti, or if you're looking for a foreign body that you can't identify, that you can't see with your eye, it's a great and very useful thing to use. Yeah, so in terms of the anterior segment, as I mentioned, you need to be systematic and look from the front backwards, the eyelids, the conjunctiva, the cornea, etc. Very important to always use fluorescein, and then to look at the cornea again with the cobalt blue light. There's no excuse not to use fluorescein and to have fluorescein in your practice. Also important to measure the corneal sensation before you place any local anesthetic in the eye, particularly if you are worried about a corneal ulcer secondary to a herpetic herpes zoster or herpes simplex virus. The other thing in terms of the anterior chamber is to do the Eclipse test. I'll just go through that quickly with you in the next slide or two. And that's basically assesses the depth of the anterior chamber if one's thinking about dilating the pupil. So that's important to check if you'd want to dilate the patient. And then obviously to check the pupils for the afferent or the efferent pupil defects. Remember, the afferent is assessing the optic nerve, and then the efferent is assessing the third nerve. And then again, also very, very important, just prior to you doing the fundoscopy, always check for the red reflex. Okay, just briefly, remember, if the pupils are very small and you're trying to look through a small pupil, it's better to put the ophthalmoscope on the small aperture. A large dilated pupil, you can use the large aperture. The cobalt blue light, don't get confused with the cobalt blue light and the red-free green, the green light. The cobalt blue is you're going to look at when you put the fluorescein in, and that's going to show up abrasions, foreign objects, etc. And it's also useful in assessing the tear film. And I also, in a few slides' time, we'll go through that. The slit is probably not that useful for you, but if something is elevated, you'll see a little, the slit will bulge out. So if you looking at the retina and you see a lesion and you want to know if it's if it's sticking out or if it's a flat lesion. And then the red free filter you probably also won't really use. It's not that important for you, but that's helpful in identifying veins and arteries and nerve fibers. Okay, so I mentioned to you the Eclipse test. So basically what the Eclipse test is, you're assessing the anterior chamber depth, and all you do is you shine the light in from the side. You can see the light, the torch light shining in there, and you're looking at the amount of iris that is lit up. You can see in this first image, very little is lit up. And that's because the iris is bulging forward anteriorly and making a shadow on the rest of the iris. So in the first and second image, you can see that there's most of the anterior chamber is in shadow. And in these cases, you definitely wouldn't want to dilate the patient, because this could result in causing angle closure glaucoma. In the grade 3 and the grade 4, you can see the whole iris is lit up nicely. So that indicates that the anterior chamber is nice and deep and definitely very safe to dilate the pupils. Okay, how and when to use eye drops? Fluorescein, always, no excuses. I think the easiest way to have fluorescein in a GP practice is probably with these strips, because you guys don't use it often, and having drops and things, they expire. So that's probably the easiest way to keep fluorescein strips. When you apply them, you can either put a little drop of local anesthetic on them before dipping it, before placing it in the patient's fornix, or if you don't have local anesthetic drops, you can actually just place the anesthetic eye drops. It's also useful to have, obviously, big bottles of anesthetic eye drops will expire, but you can get boxes of minims, which are quite useful to have, and they're useful when you need to do a proper examination on a patient and they're in a lot of pain. But never give patients anesthetic eye drops to take home with them. Dilating drops, the two that are used most frequently are tropicamide and cyclomadrol. They work fairly quickly, and they also have a fairly short duration of action. Unlike atropine, you place atropine in someone's eyes, they won't be happy with you at all because their pupils will be dilated for about 2 weeks. So definitely tropicamide and cyclomadrol are the best two to use. And as I said to you earlier, do the Eclipse test just to be safe before you dilate. Okay, this is just an example. I'm sure you guys have all seen this. So this is some nice fluorescein has been used in the eye, and you can see a nice dendritic ulcer there in the left-hand image, and in the right-hand image, the ulcer has expanded and taken on a more geographic shape. So both of these are a result of herpes simplex virus, and you'll find if you check the corneal sensation in this patient, it will be markedly reduced. Okay, as I said before, the other place where fluorescein is very useful is in measuring, looking at the tear film and measuring the tear breakup time. Janice spoke to us very nicely about dry eye and lipid deficiency dry eye. So in a case where you place fluorescein in the eye, you get the patient to blink and then open the eye. It should take about 15 seconds for you to start getting these little dry areas. In patients who have lipid deficiency dry eye, you'll start seeing this drying a lot quicker. And it's a result of the abnormal lipid layer in the tear film, and that obviously causes the tears to evaporate much quicker. So that's also very useful, particularly if patients come in with signs and with symptoms of burny, sharp pains in their eyes, dry eyes, spending lots of time in front of the computer, and those sorts of complaints. It's worthwhile checking this. And you can also look at the tear film margin. A normal tear film margin should be about a quarter of the eyelid margin. So if it's very a thin slither, then one's thinking more towards tear film deficiency rather than a lipid deficiency. Okay, as I said, when you start, so that's pretty much the anterior segment done. When just prior to starting fundoscopy, you always just have a quick look and check the red reflex. You can see in this patient, there's a nice red reflex in the right eye and absent red reflex in the left eye. And then when you examine the fundus, you're going to look at the optic disc, you're going to look at the veins and the arteries, and then the macula. So try and look through, try and look at all of those. The easiest way to look at the macula is to actually get the patient, when you're looking through the ophthalmoscope into the eye, to actually tell the patient to look directly into the light, and that will bring the macula into focus. The leukocoria, or an absent red reflex, is extremely important to check, particularly in children who can't tell you that they can't see through the one eye. Cataracts, unilateral cataracts, bilateral cataracts, retinoblastoma is actually is the most common intraocular tumor in children, and is something that we don't see all the time, but we definitely, when I worked at Provincial Hospital, we definitely see 2 or 3 a year. So it's not that uncommon. And and the easiest way to pick that up is by checking the red reflex. And then the other various conditions that you don't really need to know too much about that will also cause absent red reflex. Obviously, a large retinal detachment will also cause that. Okay, so the optic disc, there are many different things that can happen to the optic disc, but I'm just going to go through some that I think as GPs you should be able to identify. In the first image, you can see that the optic disc has very blurry margins, and one also gets the impression that the blood vessels are coursing over an elevated optic disc. So this patient's definitely got optic disc swelling. In the second image, the patient's got marked optic disc swelling. This is obviously much easier and much less subtle. You have nerve fiber layer hemorrhages, and you got marked swelling of the optic nerve. In the third image, this patient is diabetic, and you can see on the optic discs, you can see lots of fine little blood vessels. And this patient has proliferative diabetic retinopathy. There are other conditions that can also result in new vessels on the disc, other vasculitis, ischemic vasculopathies, vein occlusions, etc., can also result in new vessels in the disc. But it's important to be able to differentiate the normal appearance of the blood vessels and the very thin appearance of the new blood vessels. And then in the fourth image, a patient with glaucoma, healthy disc has a cup to disc ratio of around 0.3. So in other words, the cup should take up about a third of the diameter of the optic disc. In a patient where there's optic disc cupping, such as in the second image, you can see that the size of the cup is markedly enlarged, and this patient is likely has glaucoma. Okay, then retinal blood vessels. Also, there are many other problems that you can get with the retinal blood vessels, but this probably makes up the majority. In retinal vein occlusion, you'll find hemorrhages in all four quadrants, also some cotton wool spots and a sort of swollen edematous looking retina with a swollen optic disc. And this would be a central retinal vein occlusion, whereas in the top image you have a sectoral area of hemorrhages, and this would be a result of a supratemporal branch retinal vein occlusion. Again, a diabetic patient, instead of having new vessels at the disc, this patient has new vessels elsewhere. You know, often it is very difficult to see these, but you can see in this patient has advanced diabetic retinopathy and obviously needs referral. You can see the cotton wool spots, dot and blot hemorrhages, and exudates. This image, you can see exudates in the macular area, and this is a result, also a diabetic patient with clinically significant macular edema. In this patient, they also have exudates in the macula, but you can see that it's the configuration of the exudates is a star-like pattern, and you call this a macular star. And looking at the disc, which is swollen, the blood vessels are tortuous, and the whole retina looks very edematous and swollen. This patient has malignant hypertension. Then in this final image, this patient has a very pale-looking retina with what you call a cherry red spot. So the macula is, or the foveal area is still red. And the blood vessels are very attenuated. So this is a central retinal artery occlusion. So remember differentiating between a vein occlusion and an artery occlusion. The vein occlusion, you have a blockage, so there's a buildup of pressure and then you get hemorrhages, whereas the artery occlusion, you're not getting blood supply to the retina. Usually the image only looks like this, very acutely. After a day or two, the retina appears completely normal. And with time, the vessels become very attenuated and the optic disc becomes pale and atrophic. Okay, so these are common things that you should be able to recognize and treat: conjunctivitis, corneal abrasions, a corneal foreign body, subtarsal foreign body, a subconjunctival hemorrhage, lid margin disease, and dry eyes. I know the list doesn't seem very extensive, but this is will probably make up the majority of the conditions that you do actually see in your practice. And definitely as GPs, you should be able to manage all of these. Okay, so first of all, we're going to talk about conjunctivitis. Now, there are many different types of conjunctivitis, and unfortunately, many of them look very similar. There's bacterial, viral, allergic, molluscan, chlamydial, Stevens-Johnson's, lid margin disease, and subconjunctival hemorrhage. So they all involve the conjunctiva, and they all look quite similar, but they all have different forms of treatment. So what I'm going to do is just go through some of the things that differentiate them, that will help, lead you down the correct path. So obviously bacterial, that's an easy one. If a patient comes in with beefy red conjunctiva and a thick yellow discharge, the most likely thing is bacterial conjunctivitis. Viral conjunctivitis and allergic conjunctivitis are sometimes quite difficult to differentiate. Sorry, I'm now drawing on are quite difficult to differentiate. Viral conjunctivitis has a watery discharge. Adenoviral conjunctivitis, which is the most common type, will frequently have a preauricular lymph node. So if you have a preauricular lymph node, then it's highly, highly likely that you've got an adenoviral conjunctivitis. Viral conjunctivitis, also, they usually have follicles, whereas allergic conjunctivitis, they usually have papillae. So I'm going to go through the difference between papillae and follicles on the next slide. Molluscan, also, as I said, it's very important to look at the rest of the eye. And molluscum, if you examine the eyelids, usually these patients will have small little eyelid lesions, and these tiny little eye lesions can cause a chronic follicular conjunctivitis. So very important to look at the eyelids in patients with conjunctivitis. Chlamydia also gives you a chronic conjunctivitis, also a follicular conjunctivitis. So in cases with the chronic conjunctivitis, it's always important to consider chlamydial and perhaps do a swab. Lid margin disease, we're going to go through a bit later. Stevens-Johnson's usually will have other mucosal involvement, and subconjunctival hemorrhage we'll also talk about. So the difference between papillae and follicles, papillae are basically edematous conjunctival tissue, and they aren't able to expand because of the connective tissue between them. Large papillae can be called giant papillae, and papillae you see very commonly in contact lens wearers. Contact lens wearers with the irritation can get a giant papillary conjunctivitis. Whereas follicles are actually little mounds of lymphocytes, and follicles usually look like little nodules, and they look like rice grains on the tarsal plate. Okay. Bacterial conjunctivitis. Bacterial conjunctivitis, as I said, is quite easy to pick up. The question is, should you treat these patients with antibiotics? Antibiotics certainly do speed up recovery from conjunctivitis, but the benefits are marginal. And over 90% will actually resolve spontaneously in a week or two. So in cases where you have persistent conjunctivitis or very severe conjunctivitis, it would be very reasonable to withhold antibiotics. Viral conjunctivitis is usually bilateral acute. As I said, you have a watery discharge and follicles. In very severe cases, you can get subconjunctival hemorrhage and pseudomembranes. You can see the pseudomembranes in this image. And in severe adenoviral conjunctivitis, you can also get subepithelial infiltrates, which can go on for 6 to 9 months, and these patients require treatment with topical steroids. With viral conjunctivitis, it's basically the treatment is symptomatic. You need to reassure the patient and perhaps give them some artificial tears. As I said, molluscum. So you can see in the top image that there is you see these two little eyelid lesions, and in the bottom image you can see some little eyelid lesions medially there. So the only thing that is going to cure this conjunctivitis is by actually removing these lesions, and they're fairly easy to remove. All you use is you can use the little curette that you use for incising and draining meibomian cysts, and you literally just curette them out. Sometimes they are quite extensive, and you can have multiple. But often if you just curette out a few, it's a bit like a wart. If you start removing one wart, the other warts disappear. Okay, chlamydial conjunctivitis is a very common cause, well, not a common cause, but is one of the main worrying conjunctivitises that neonates can get. It does occur quite late, so usually 1 to 3 weeks postnatally, whereas gonococcal conjunctivitis is, in the first few days. It also may be associated with systemic features such as otitis, pneumonitis, and rhinitis, and the patients have a follicular papillary conjunctivitis. Very important to refer these patients. Adults have also, as I said, a very chronic conjunctivitis, follicular, and if you have a high index of suspicion, it's important to do serology and a swab, and they actually get inclusion cells they see on the swab, and it's quite easy to treat. Usually you can use doxycycline or azithromycin. Okay, allergic conjunctivitis. We all know, we see hundreds of patients with allergic conjunctivitis, and it can be anything from mild to severely debilitating. And obviously the treatment needs to be tapered as to the symptoms. Cool compressors help. Antihistamine eye drops such as Retinol, Relistat, or Spersalurge. Retinol and Relistat are better than Spersalurge. They are a lot more expensive, but they also have that mast cell stabilizing effect. So whereas Spersalurge is purely antihistamine. It's also important when you advise patients to use these drops, not to use them for a day or two and then stop and then use them for 3 days later. It's important to use them consistently after an episode of this for a month to get those mast cell stabilizers, to get everything stable, and then thereafter they can discontinue. Lubricants also help by diluting the allergens, systemic antihistamines if a patient's very, very itchy. And obviously, if you have a very severe non-responsive, one can use topical steroids or even subtarsal steroids. So one can actually inject the celestone supratarsally. Also very important, particularly in kids, is to discourage them from rubbing the eyes. Chronic rubbing is one of the big causes of keratoconus, and often, teenagers who present with signs of keratoconus were chronic eye rubbers with allergic conjunctivitis. As kids, they actually break down the connective tissue bonds in the cornea, and this predisposes them to the development of keratoconus. Subconjunctival hemorrhage, I'm sure you guys have seen lots of this, and we all know it does not affect vision and has absolutely no visual consequences. But importantly, always measure the blood pressure, just to make sure. And if these are occurring recurrently, it's also important to check the patient's platelets and clotting profile. Okay, what is this and what to do? Again, I'm sure you've seen this many times, patient grinding either with goggles or without goggles. They've got a metallic foreign body in the cornea. I think it is something, if you can't get hold of the specialist on call or whatever, if you're happy to attempt removal, the important thing is to consider the mechanism of injury. If it was a very high velocity injury, then it's probably better to refer, because there is always the risk that the patient has an intraocular foreign body, and often one doesn't see the entrance site. But if it's a low velocity injury and this patient has a corneal metallic body, then the best thing to do is to actually use a needle. I know often one tries a cotton bud, but basically what the cotton bud will do will just abrade the cornea, the corneal epithelium around the foreign body, and perhaps even push the foreign body, the metallic foreign body further in. So the best is just to use some local anesthetic and then just try and get it out with a needle. And then thereafter apply some topical antibiotic drops, and probably best to see the patient 24 to 48. It usually takes about 24 to 48 hours for the cornea to re-epithelialize. In instances where the foreign body has been there for a number of days, they often have a surrounding rustring. In those cases, it's probably better to refer to an ophthalmologist. So we actually use a little corneal burr to remove that rustring that remains. Okay, so these are some examples of what you can see with fluorescein. In the first image and the third image, you see a large corneal ulcer. You can see that the cornea is very hazy. There's a hypopyon, in other words, pus in the anterior chamber. You can see that layer there. There's stromal infiltrate, suppurating. So this is the suppurating keratitis. And in these instances, you refer the patient immediately. We would perform a scrape and then start immediate antibiotics. In the second image, this patient had a scratch to the eye and has a large corneal abrasion. If you're confident with the history and you can see that the cornea is clear, there's no stromal infiltrate, then as GPs, you can definitely manage these. The best thing to do is to give them some dilating drops just to relax a ciliary spasm and to take away some of the pain, and then to give them topical antibiotics. You should see them again 24 hours later, and by that stage, the corneal epithelial defect should either have gone or have reduced significantly in size. In terms of pressure patching, I usually actually just put some antibiotic ointment in. Often patients complain of more pain with the eye closed. But if they are more comfortable with the eye closed, then you can also patch them. But I don't necessarily always patch them. In the fourth image, you can see an interesting looking slide with linear staining, and this would be as a result of a subtarsal foreign body. So every time the patient blinks, he scratches the cornea. So also very important when a patient has a foreign body, always to check underneath the eyelid. Okay, bacterial keratitis. You guys don't need to know much about this other than that very important. You need to refer these patients. Again, here's a nice herpetic example of a herpes keratitis, and then in the second image, a slightly larger, more geographic ulcer. Okay, Herpes Ophthalmicus. It's often not as obvious as it is in this image, but herpes ophthalmicus is when the zoster virus affects the ophthalmic branch of the trigeminal nerve. And in the first image, with the arrow, you can see that the tip of the nose is involved, And the tip of the nose is supplied by the nasociliary nerve. And this nasociliary nerve also supplies the cornea and anterior chamber. So if you have involvement of the tip of the nose, which is also known as Hutchinson's sign, you must always look, it's very likely that the patient has eye involvement. And the eye involvement is usually in the form of a similar dendritiform ulcer that you get with herpes simplex. And then patients can also get a uveitis. And the uveitis that they usually get is a granulomatous uveitis. So you see these large mutton fat KPs on the cornea. But herpes zoster and herpes simplex can actually affect the eye. They could cause optic neuritis, it can cause squints, it can cause a retinitis, it can cause retinal necrosis. So both these viruses can affect the eye, and nearly every part of the eye can be affected by these viruses. Okay, acute glaucoma. So now we're just also looking at some other causes of red eye other than conjunctivitis. Acute glaucoma is a clinical diagnosis. The patient will come in extreme discomfort, will have a severe headache, will be nauseous, may have vomited, will have severe photophobia, severely reduced vision, a hazy cornea, fixed mid-dilated pupil, an injected conjunctiva, and lots of tearing. So these patients are extremely uncomfortable. If they aren't uncomfortable, then it's very highly unlikely that they don't have acute glaucoma. So just quickly, how acute glaucoma happens in a normal patient with a normal eye anatomy. The aqueous humor is made by the ciliary body, which is over there. It circulates in front of the lens, through the pupil, and then into the anterior chamber, and then it exits through the trabecular meshwork. Whereas in a patient with angle closure glaucoma, or a patient with a shallow anterior chamber and predisposed angles, what happens is when the pupil dilates to a certain amount, it actually touches the lens, and that inhibits the aqueous humor going into the anterior chamber, and as a result, there's a buildup of pressure in the posterior chamber, and that causes the iris to bulge forward and close off the angle, and then obviously the aqueous can't drain off and the pressure goes up very, very high. And I think this is the one thing, if you encounter a patient at 2 in the morning, it's the one, thankfully for us as ophthalmologists, it's probably the only one thing that you can expect an ophthalmologist to come in at 2 in the morning to sort out. So yeah, very important. If you do suspect this and the ophthalmologist isn't wanting to come in, you really need to insist that the patient is managed correctly. Okay, if you do have access to anything, probably the best thing to do would be to give or prescribe the patient oral Diamox while they're on their, give it to them while they're on their way to the ophthalmologist. 500 milligrams pilocarpine drops constrict the pupil, and if you have those available, they can also assist in breaking that block. And then, as well as timolol drops, if you have them available, you can give the patient Maxilon, some analgesia, and as I said, refer immediately. Iritis or anterior uveitis will also give a red eye, and patients are also often quite uncomfortable and photophobic. Remember, the injection, the eye will be red perilimbally, so around the limbus. So they won't have a diffusely red eye as they will in conjunctivitis. Often, if they have a granulomatous uveitis, they'll have mutton fat KPs, as I showed you with the zoster, but not always. You may see a hypopion, which is the lymphocyte pus cells sitting in the anterior chamber, and they often have anterior synechiae. Again, uveitis is often associated with other systemic conditions, so it's important to get a history on rashes, other infections, etc. And it can also be associated with many autoimmune conditions. So again, it's very important you refer these patients. Blepharitis. Blepharitis can be divided into anterior and posterior blepharitis. Basically, anterior blepharitis is usually due to a hypersensitivity reaction to the lid microflora, and they get these little crusty lesions around the hair follicles. And the other type of anterior blepharitis is staphylococcal blepharitis, where you actually have active infection around the hair follicles. And both of these conditions can give rise to meibomianitis and secondary dry eye. You treat this with doxycycline. Posterior blepharitis is extremely common. Every second patient in ophthalmic practice has meibomian gland dysfunction and posterior blepharitis. And so it's something that we manage all the time. And you can have anything from meibomian gland hyperactivity to full-blown meibomianitis. And as we spoke earlier, basically the fatty layer the lipid layer that is made by the meibomian glands is dysfunctional, and this results in secondary dry eye. The way in which I treat them is you can either use prescribed Naviblef, which is a type of eyelid shampoo. It is a lot more expensive than baby shampoo, but it does work. It does work well, and it also works on the little lice. Sometimes it's got tea tree oil in it, and sometimes patients who are allergic to tea tree oil may react to this, may get an allergic reaction to it. But other than that, it does work really, really well, and the bottle does last long. Other option is just to clean the eyelids with baby shampoo. Prior to cleaning the eyelids, I always tell the patients to do warm compresses just to warm up the secretions. Then you wash the eye. And then you can either apply lubricating drops such as Optive or Sustain. Topical steroid antibiotic combination can also be used if a patient has very severe meibomian gland disease. And doxycycline is also extremely useful, not because of the antibiotic part of it, but it's actually a matrix MMP, matrix metalloproteinase inhibitor. And that helps to soften up the secretions. So if there's a poor response and the patient still has severe meibomian gland dysfunction and dry eye, the patient may need cyclosporin or autologous serum. Okay, collagens. So leading on from the meibomian glands, if the meibomian glands become blocked or you have meibomian gland disease, often these patients can get a meibomian cyst or a collagen. The problem with these is they do frequently recur, so I definitely don't rush into incising them on the first visit. I prescribe warm compresses, lid massage, lid hygiene. One can also give them doxycycline and a topical antibiotic steroid combination. And if they don't resolve after a couple of weeks of doing this, and it's really bothering the patient, then one can consider incising and draining it. A stye is different from a meibomian cyst, and it's actually an infection of the hair follicle. So it's far more anterior. You don't develop this. You don't have this big nodule. And a stye, you can just apply some. If there's a little pussy head, you can maybe lance it with a needle and then apply antibiotic ointment. Eyelid cysts is also something that we see that you guys see very commonly, that I see very commonly. These eyelid cysts are completely benign, but they often irritate the patient, and the patients don't like the way they look. So I spend a lot of time removing these things. And the different types you get the cyst of mole, cyst of Zysis sebaceous cyst, and a sweat gland hydrocystoma. Basically, what a cyst of mole is it's a sweat gland hydrocystoma on the lid margin. So like this. So it's a clear fluid-filled little cyst on the eyelid margin. And if you put a needle in, you'll drain out clear fluid, but unfortunately, a day later, it will look exactly the same again. So the important thing with these is you need to actually excise the entire cavity. So these patients will obviously, if they would like it removed, they need to be referred to an ophthalmologist. Cyst of Zeiss is similar to, is basically a sebaceous cyst, but on the eyelid margin. Okay, then I'm just going to talk about a few lesions of concern. You have the basal cell carcinoma, are extremely common on in the face and extremely common on the eyelid. They're the most common eyelid tumor and make up about 80 to 85% of eyelid malignancies. Similar to the rest of the body, they have these pearly margins with a central area of ulceration. You often see loss of the eyelid architecture. They are only locally invasive, but the medial canthal ones, in other words, the ones medially near the puncti, can actually spread. Can spread very far back, and a patient can end up even needing an exenteration. So it's very important to identify these tumors and to excise them timeously. Squamous cell carcinoma may resemble basal cell carcinoma, but it's much less common, and it only makes up about 5% of lid tumors. It's much more aggressive, and unfortunately, they're often large areas of subclinical involvement, tumor involvement, because it can spread neurotrophically. So it often spreads up the nerves into the orbit, and even into the brain. So very important to also identify and remove these. Malignant melanoma, fortunately, on the eyelid is extremely uncommon and only makes up less than 1% of eyelid tumors. I think the important thing for you to remember is that not all melanomas are pigmented, and not all pigmented lesions are melanoma. So generally, if you have a larger lesion, a new onset lesion, or a change in an existing lesion, you definitely need to worry about these. And the way in which we treat them is by wide excisional biopsy. We don't do incisional biopsies for malignant melanoma. Sebaceous cell carcinoma is actually a rare tumor in South Africa, but is actually very common in India and is one of the most common eyelid tumors. And the problem with sebaceous cell carcinoma is it's a great masquerader. And often patients look like they've got a chronic unilateral blepharoconjunctivitis. It just isn't resolving. It can even present looking like a meibomian cyst. So in these things that aren't resolving, definitely worthwhile doing a biopsy. With biopsies, often they're difficult to biopsy because it's difficult to see where the tumor ends and where it starts. And so when we biopsy these, we often do map biopsies because they can also you can get skip lesions and they can move. You can find different. There can be a big gap between the tumors where there isn't tumor. There is a risk of lymph node metastases, and death is possible, but rare. Okay, infective emergencies. It's very important to differentiate septal and orbital cellulitis. In preseptal cellulitis, the patient will literally only have eyelid swelling and eyelid edema and redness. With an orbital cellulitis, the patient will have chemosis. In other words, you can see in this image, the patient's conjunctiva is swollen and chemotic. Their eye movements are reduced. They often have proptosis and decreased vision. So it's and so it's extremely important to have a look at the eye. Often a patient with preseptal cellulitis or a swollen eye, you know, they'll come in and you can't open the eye, but it's no excuse not to open the eye, because you need to differentiate between the two. And the best way of doing this, if you have a speculum, which is probably unlikely, that would be the easiest way to to open the eye. But if you don't, there's what you call the paper clip trick. So you just open the paper clip out, and you can just bend over the end. You make 2 of those, and then you just slip those. They work really, really well. You just slip those, put some local topical anesthetic in, and then you just put those under the eyelids and open the eyelids. Ask the patient to move the eye around, check the cornea, and check for chemosis. Okay, preseptal you can just treat with oral antibiotics, whereas orbital cellulitis, you need to refer those patients immediately. They need IV antibiotics, they need a CT scan, and often they need surgery. Often the cause can be a sinusitis. The patient may have intraorbital abscesses that need drainage. They often need referral to the ENT surgeon. Okay, the complications of orbital cellulitis are blindness, cavernous sinus thrombosis, meningitis, brain abscess, encephalitis, and death. So very, very important to identify these cases. When you have a patient with bilateral, what appears to be bilateral orbital cellulitis, it's highly likely that that patient has cavernous sinus thrombosis. The infection actually travels up the superior ophthalmic vein into the cavernous sinus and then down into the other eye. Yeah, and these patients are very, very sick. Ocular chemical burns is also something that you encounter commonly in GP practice. It's also a medical emergency. It's important to have a speculum, something to open the eye. Topical anesthetic, also important to examine the eye effectively, and will also help with the whole washout process, make it much more pleasant for the patient. And then the key is to wash, check pH, wash, check pH. So you need to really, really wash those the eyes out. You can either use normal saline bags, but any water is fine. And obviously never neutralize, try to neutralize the pH with the opposite pH. Dipsticks is a very useful way. No one really has litmus paper nowadays. So what I usually do is just cut off the dipsticks at the pH line, and then you can use that to dip it into the fornix. Another useful trick that I learned at Tygerberg when I was specializing there is the butterfly irrigation trick. So you cut off the needle of the butterfly and then tie a knot in that end, and then use the needle to make lots of little holes all the way along the tube, and then you put it in a loop, and then you can actually stick it into the fornix, and then just attach it to a bottle of saline and hang the patient over a bowl, and just run fluid in, and that works really, really well without you having to stand there continuously dousing the eye with fluid. Okay, so just some red flags for, I know we've gone through most of this, but red flags for immediate referral to an ophthalmologist. If a patient's got sudden loss of vision or a visual field defect, one's thinking of retinal detachment, etc., artery or vein occlusion. Sudden onset of diplopia, one worries about an aneurysm, expanding aneurysm, particularly with sudden onset third nerve palsy, associated headache or scalp tenderness, one's thinking of giant cell arteritis. These patients need to be referred urgently. Flashing lights and floaters, possibly an impending retinal detachment. Red painful eye, cellulitis in children we've talked about, pupillary distortion or abnormality, an abnormal looking fundus or disc with acute symptoms, a hazy cornea. We know the biggest cause of that is obviously glaucoma or corneal ulcer, chemical injuries, and then obviously the mechanism of injury. If you've got a patient with a high velocity injury, then you really need to consider a intraocular foreign body. And then yellow flags for less urgent referral are gradual reduction in vision, abnormal optic disc or fundus with non-acute symptoms, chronic mild symptoms, elevated intraocular pressure but less than 30. So the normal intraocular pressure is around 20. Acute angle closure glaucoma will give you a pressure of around 60. So a pressure of around 30, one would be thinking more of an open angle glaucoma. Chronic mild symptoms, no response to your treatments, suspicious lid lesions we talked about, and obviously children if any doubt at all. Okay, pitfalls. Not measuring vision. It's very easy to measure vision. You don't necessarily have to have a Snellen chart, but all you need to do is close one eye at a time, check if the patient can see hand movements, can see light, can see your finger counting, or can read a magazine or a newspaper. It doesn't need to be exact, but I think it's important, very important that you check that. Again, not using, I've emphasized this a lot, not using fluorescein, the inability to do fundoscopy or even try to do fundoscopy. And then also fixating on the eye and missing skin vesicles, like I showed you with the molluscum or herpes zoster, etc. Not considering the mechanism of injury, not looking at the red reflex, not checking confrontation fields, not looking at the pupils, and then prescribing inconsistent with the diagnosis. So basically just giving everyone artificial tears or prescribing them topical steroids when you're not really sure what's going on. And then most importantly, not referring or discussing in doubt. When in doubt, refer. Thank you.
Thanks very much, Dr. Read, for a most informative presentation, valuable and most appropriate for GPs. So you hit the spot. Thanks very much. And technology was kind. So
yeah, sorry about what's all these lines everywhere. Is that me?
I think that's your sub A inclinations. It happens sometimes when you touch the slide and you've got the marker on. Then it.
Oh, okay. Yeah, I didn't want to start fiddling with it while I was doing my talk. So I'll have to get rid of all those lines. So sorry about that.
Not a problem. If you didn't tell us, we would have assumed that it was intentional.
Yeah.
Dr. Read, just to kick off a few questions.
Sure.
Firstly, I don't know if you're going to make a note. Then I'll just run through the questions. So,
sure.
If there's a red eye and the GP is unsure, what should he do? That's one.
Mm-hmm.
Number two, I noticed that you mentioned doxycycline for certain eye conditions.
Yes.
What would be the appropriate antibiotic for children?
In children, depending on what it is, obviously, yeah, one can't use doxycycline in children, but erythromycin it works well. So if one's like a chlamydial conjunctivitis or conjunctivitis, erythromycin is probably the best one to use.
Okay, thank you. And then from Dr. Nana, who posted on the chat, can one use Patanol or Relistab drops long term?
Yes, certainly. One can definitely use them long term. I think one doesn't necessarily need to use them long term. I think that the key is to try and get on top of the allergy sooner rather than later. And I think what often happens is patients use the drops for a few days and then start to feel better, and then they stop using them, and then a week later it flares up again. Whereas I think if you use it consistently for a month, it will actually settle the whole eye down, and the chances of a recurrence sooner would be unlikely. But I mean, one can use it long term.
So how long will be too long?
Obviously, I mean, in all drops there are, even though it's not, they don't have, back and bad preservatives in, I would say I wouldn't use it for more than 6 months solid without stopping.
Thank you. And then the last question is, in GP practice, could you just guide us on measuring intraocular pressure?
Yeah, so in terms of, I mean, I know it is very difficult for you as GPs to measure the intraocular pressure without having a tonometer. It is one does have there's a toner puff and there's a toner pen, which is a lot easier to measure, but they still are quite expensive. So it's probably not worth your while going and getting one of those. But basically, digitally, what you do is you use your you can use your 2 index fingers, and you get the patient to can you see me, because I can't see myself?
We can see you.
Okay, you can see me. You basically get the patient to close their eyes, and you just use your index finger and you just blot the eye above the tarsal plate. And if you feel on your own eye, you should feel that you can just indent the eye. Usually in patients who present with acute angle closure glaucoma, in 99% of cases, it's going to be unilateral. So if one compares the normal eye with the hard eye, you'll definitely be able to see that there's a difference. In terms of patients with open angle glaucoma and pressures of 25 and 30, I think it would be difficult for anyone to differentiate between a pressure of 15 and a pressure of 30. But certainly, if the pressure is very high, you would be able to. It would be the eyes rock hard.
Okay,
so the important thing is to feel above the tarsal plate, so that you're not palpating the tarsal plate.
Okay, and then the first question, red eye and the GP is unsure.
The red eye, I think the important thing is, first of all, to assess vision. So if the patient has normal vision and the conjunctiva is diffusely red, then it's highly unlikely that it's some sort of conjunctivitis. And you can go through the different types of conjunctivitis and then treat appropriately. If the vision is reduced in any way, even slightly reduced, then I think that all those cases need to be referred to an ophthalmologist. And then also looking at the nature of the injection and the redness. If it's diffusely red, then the most likely thing is conjunctivitis. If you open the eye and look in the sunlight and you see that it's just around the limbus or more red around the limbus, then it's much more likely that you're looking at a uveitis. Obviously, I didn't go through episcleritis and scleritis. Those are also things that one does see fairly commonly, particularly episcleritis, and that's usually sectoral. So if you see a triangular area or small area of the eye that is red, that's possibly an episcleritis. With a scleritis, the eye is actually tender and it aches, when you move the eye around. So so I think definitely if the eye is diffusely red and the vision is normal, it's highly likely to be conjunctivitis. And I think definitely as GPs, you could probably manage that, for some time, unless it's not getting any better.
Okay. Anyone else would like to ask a question? You may raise your electronic hand if you can find it. Otherwise, unmute and ask your question.
Hello, how long can you use Optifusion post-cataract surgery? Because I got patients who...
Yeah, you can use it long, Optiv, you can use it long term. You can use it forever. The patients often after cataract surgery, for some reason, I think it's because one is cutting into the cornea, it disrupts the nerve supply. patients often do have very dry eye for about 3 months after cataract surgery. It does usually settle down after a few months and go back to their, pre-cataract surgery stage. But, we've got lots of patients who are permanently on dry eye drops.
Thank you.
Thank you for that question, Dr. Sikander. Any other questions? Just unmute and go ahead. It's a great opportunity. You want to ask another question, Dr. Sikander? Please go ahead.
No, I was just thinking that there is a situation when we look at eyes in practices, and we have a mixture of people with viral type of diseases and bacterial. And I find that a lot of people get these combination corticosteroid type of preparations, Specidex compound and all that, and they come in with it. So you get a response, but the patients then, seem to go on it more permanently. And obviously that's not right. We tell them no, but they say, look, we're not getting better, like type of thing.
Yeah, no, it's definitely, Specidex comp and, any type of steroid eye drop, unless it's really, really indicated. You do get some patients who have severe atopic keratoconjunctivitis who do need to be permanently on topical steroids, but it's a very, very, very few. And I know, the problem is once patients have been prescribed it, they often do see such a marked difference that they want to. But the good thing with topical steroids is that they need to be prescribed it. So if they're not prescribed the topical steroids, it's not something, it's not like the lubricating drops that they can just go and get on their own. Someone needs to prescribe them that, and one obviously shouldn't.
And finally, the last thing that we see quite a lot of is that you see a patient who's had an AI condition and had treatment for it. They don't dispose of their eye drops, they leave them. They get somebody in the family who gets something similar, and then they start using it, and it's post 30 days. And they come to you and they've got now a problem which is due to the fact that they've used those drops, which they're not supposed to use.
No, exactly. You see that all the time.
All the time. It's a difficult situation to get around. That's life. Okay.
Thank you, Dr. Sikander. Those were good questions. Dr. Logan Naidu would like to know, what are the non-drug measures to manage conjunctivitis? So I suppose he's including medicated drops as a drug measure.
Yeah. So the non-drug, cool compressors. Do you mean drops, Logan? Do you mean drops wise or just non?
Basic home hygiene methods like stop rubbing, maybe apply some or occlude the eye, that kind of measures. What would you recommend?
Yeah, I would say, cool compressors will help from a symptomatic point of view. It depends if a patient's got chronic blepharoconjunctivitis from inflammation of the meibomian glands, then in those cases warm compressors would help to try and soften up the meibomian secretions. And then, as I said, eyelid shampoo, one can either buy it or one can just use Elizabeth Ann or Johnson & Johnson's baby shampoo. And you actually close the eyes and basically you create a foam on your fingers and rub the eyelids with the with the shampoo, and then wash it off quite thoroughly. But aside from that, I don't have any other home remedies.
Like something like irrigating the eye with like saline.
I think. I think if you've got an extensive pussy discharge, it would help to irrigate the eye. But I don't think it's going to make much difference. It may make the eye a little bit more comfortable, but I don't think it's going to speed up the process of recovery. Sometimes in patients with severe adenoviral conjunctivitis, they can get those pseudomembranes, and sometimes those pseudomembranes actually need to be removed with a cotton bud. But that's, you know, in very severe cases.
And avoiding bright light, would that be of any benefit?
It wouldn't, from a symptomatic point of view, it would help the patient, but it's also not going to, it's not going to speed up the process of recovery.
Thank you, Dr. Naidu. Dr. Read, with migraine, slightly outside of this, sometimes you get eye symptoms. What's the mechanism of action of that, you know, where photospectra and so forth?
Yeah, it's more so it's the brain. So it's a vascular spasm in the brain, and sometimes if it's in the occipital cortex or around the eye, you get the difference. Often there's an issue between differentiating between a posterior vitreous detachment and the visual symptoms that you get with that, and actually an ocular migraine. With a PVD, the patients will complain of, you know, lightning flashes, whereas with an ocular migraine, you also don't always have to have associated pain, but often it's more of a scintillating sort of like a scintillating light rather than a flash of light. Yeah, I don't really know too much. I mean, I don't usually with an ocular migraine, if a patient does have severe pain, I often refer the patient to a neurologist for further management. But if I'm comfortable that it's, you know, an ocular migraine, the patient doesn't have any pain, then you know, I just reassure have a good look at the retina, make sure it's not a PVD, and then reassure the patient.
Thank you, Dr. Read. So it's now almost 9 p.m. So that's how captivating it was. We had a good attendance of about 75, Dr. Read, from around the country. Thank you for enlightening all of us. As most helpful. We look forward to hearing from you again. I'm going to ask Dr. Lucky Govender to do the vote of thanks.
Great. Thank you very much. Thank you very much for inviting me to talk.
Okay.
I really appreciate it.
It's a pleasure, and thank you. Dr. Lucky?
Hi, good evening, colleagues, and Dr. Read, our sponsors, and to Dr. Read, I think we'll start with you, being our main presenter and only presenter, not only good looking, but brains as well. And I always say a woman has it all. Thank you so much. It was very interesting, captivating, and I'm so happy you're down the road, because I'm at Mercantile, and we've got Pelila at Mercantile, but it was really very, very concise, excellent presentation for all of us as GPs. And it took me down memory lane. You talked about India, and I qualified in India. So yeah, brought back memories. Unfortunately, 40 years ago, when I was an intern, we didn't have much, teaching in ophthalmology those years. And even when we came back to South Africa and did internship, we didn't have to do an internship in ophthalmology. But yes, again, very informative, concise, excellent talk. And I must say, yes, we do see a lot of that in our private practice. And I'm sure it's going to be very useful for all of us. Thanks again. Go well and keep up the exercise. I love it.
Yeah, thank you.
Thank you very much.
Thank you.
Jeff, do you want me to say thanks to our sponsor, this presentation at this point? Or?
Yes, go ahead.
Okay. To Allergan and our representative, Megan, Yanis Prinsloo, excellent. Thank you so much for sponsoring us. And we hope to hear from you more in the future and have more interaction with you guys. Personally, I do use a lot of your range, and I find them very, for GPs, they're easily accessible and well priced. Thank you. To Galtia from the ECIPA office, thank you for putting all this together for us always. And then to all our attendees, thank you so much for attending. And my 75 broke the record, I think. To our ECIPA team, Dr. Jeff Govender, Dr. Gavin April, Dr. Musaji, Dr. Mohammed Paruk, Dr. Wanda Biana, and myself. We'd like to say thanks, guys. We try our best, and we hope you are happy with what we can offer. And go well, stay safe, all the best. Good night.
Thank you, everybody.
Good
Bye-bye.
night.
Take care.
Thank you.
Bye.
Bye.